right. Yeah. So, Ishaq, tell us something about yourself so people could see you. And let me focus the microphone over here. Mr. Ishaq is a handsome fellow over there.
I'm from your hospital. You met me before. I'm Hazam.
Ah, you were there. Oh, okay. Now I feel shy. Okay. Right. Thank you very much, Mr. Ishaq. Now, your request are recorded. Yes, let's record it. Now, let me ask you. So, have you done the quiz? Have you done the mock examination? How was the mock examination? I saw Ronel did a good job in the mock examination. Yes, congratulations. Have you done the mock examination, I suppose?
On one day.
Oh, one day.
Once I just try to submit, it's failed.
Yeah.
So again, it's not coming.
Oh.
Because I thought it's like for process. I started from morning till next day morning. It's like in between duty.
Oh. My
Later
goodness.
I noticed that time.
Yeah. So it has actually a time.
Yeah.
But good job. I saw also Rashid did the examination. How about you, Miss Priyanka? Have you done the mock examination? Trying to pull out the mock examination here.
I did. I completed. Yeah.
Ah, you did. Very good.
Yeah.
Very good. How was it? Any feedback?
Yeah, it was good, but some part, like, when it comes to some theoretical part, I think,
Yeah.
I was a bit confused. But apart from that, yeah, it was good. It was a good experience.
Yeah, I thought you did it pretty well. I saw the scores are very impressive. A lot of
Really?
you got, yeah, I saw the scores are pretty impressive. So the benchmark, this is because this is the first mock examination. So we expect people who have a little, okay, and so much background. So some of them might have little background, some of them have a lot of backgrounds. So we set the expectation at least 35%. And a lot. Almost, I think all who took the examination have exceeded 35%. There's even one who take about 95%. Like, wow, that's impressive. That's impressive. Very good. So, thank you, Miss Priyanka, for taking the examination. So, Miss Priyanka, thank you so much. Miss
Yeah, thank you.
Nadia, Miss Nadia,
Yes.
hello.
Yeah.
Hi.
Good morning.
Have you taken the
Hi.
examination?
Yes.
How was it?
It's difficult for me because I haven't an experience with quality, but
Yeah,
I try. I
yeah,
guess my score it's good for me.
yeah. I think it's good. It's okay. It's okay. So the idea is just to assess, everyone's
Yeah.
understanding. Yeah, yeah.
Mhm.
So far, where is everybody in terms of understanding quality concepts? So where are they in terms of their background, their experience, their knowledge? So we just wanted to see where are they, so that when we do the lectures, the sessions, we make sure that we cover and help people who are really uh, striving to get the examination. So we are
Yes.
connecting also in other areas. Let me go connect with Zoom here. And I saw Ronel. Hi, Ronel. Good morning to you. Let me unmute you, Ronel. Let me help you unmute. Ask to unmute. There you go. Hi, Ronel. How are you?
Hi, sir. Good morning. I'm good.
Hi.
I'm good. Thank you.
Oh, we missed you during the induction. You were failed to introduce yourselves. Go ahead, introduce yourselves and tell us something about yourself so people would know you. Maybe
Uh,
one section, one batch. I was speaking. They were attending sessions. They did not know that they are working together in the same hospital. One is in the operating theater. One is in the biomedical. One is where is it? In the dental, and one is in the peri-operative. And said, I'm working in this hospital. Ah, really? I was working there too. But they don't know each other. So I think it's fine. Ronel, tell us about something about yourself.
yeah. My name is Ronel, and I am also working in the hospital, but I think it's very different area. I am working in mental health services.
Oh, in the mental health services. Which hospital are
Yes.
you right now?
Hamad Medical. HMC,
Oh,
sorry. Yeah.
Okay. So right now you are in Misaid or you are in Doha?
Misa Eid, sir.
Oh, Misaid. Okay. So I think you pretty got a lot of patients there coming over.
Yeah, yeah, yeah. It's all over the place. And
Oh.
sometimes we're also admitting coming from the airport.
Mm. Okay. So there's a lot of mental health patients. I don't know if it's really a trend or what, but people are having a lot of mental health issues, breakdowns that we haven't seen before. In the statistics of hospitals that we have, we look at like there are very few. Now, I think there's a lot of patients that are uh, attending the mental health. Now, let me join the computer audio.
Recording in progress.
Okay, sorry. There you go.
Good morning.
Yeah. Hi, good morning. How are you? Yeah. What's your good name?
Rashid.
Rashid.
Yeah.
Rashid, are you the one in the operating theater and you just come in now?
No, IP2.
Ah, IP2.
Yeah.
In Hassan?
Yeah.
Oh my goodness. Are you both together? I have to. Okay. All right. Let us see if we can share the slides now. Send request. Okay. Now. So I'm now going to share the slides. And there are some people here who happen to be my colleagues, who happen to be working with me in the hospital. Okay, there you go. What are the odds that we'll see each other here? Okay, but it's nice. It's nice. I'm very happy that I see that you are uh, having an interest in quality. And actually, we have like about every month we have 3 sessions for quality. All right, there we go. So we are now going to start with the first session, our CPHQ exam preparation course. Let me just close the door. Oh, thank you. So Rashid, have you taken the examination?
Yeah.
You taken the,
Yeah.
and you did pretty well. You did pretty well. So I'll show you the scores all later on. Yeah. So, in the previous batch, they get 10 over 200. And that's fine. That's fine. We're not expecting people who are very good, but people are getting like 50, 40, getting like 60. And that's pretty impressive. All right. So let us start with our session number 1. But before that, I'd like you to take a look around you. Maybe there are some hazards like me right now here. There's a lot of cords. At least we are aware. We are looking at it, and we are able to make sure that we take care and we can be careful with it so that it will not harm us. All right. Okay. So now in session 1, we're going to talk about health quality concepts. It's kind of an introduction to quality. Okay. So I will be sending you all the slides plus notes. So I think the slides will be done very fast. So in case that you needed me to repeat something, let me know. All right. And yeah, I remember last time we have somebody driving as well, listening while they are driving. They have just their speaker mode, but still, I would recommend that you park, you go in the bay, or you stop driving. I mean, you go somewhere safe. Sometimes because you need to focus on the road. All right. So in session number 1 on health quality concepts, we're going to talk about quality and quality improvement. So we're going to talk about quality in the context of healthcare. Quality is not focused on healthcare. Actually, healthcare is one of industries that have adopted quality. Okay? And we're going to talk about measures, tools, data, challenges, trends, and promises. And we're going to shift immediately to performance improvements. All right. So today, we hope that you will be able to understand and define health quality and its importance. Okay, why is it important? What are the different dimensions of care? The different frameworks for improvement? Why do we need to do quality in healthcare? And we're going to look at some examples of quality measures and tools and different stakeholders in ensuring quality. Now, stakeholders is because quality is our hospital is an organization. Okay, so it's not like a business where it's a one-man team. There's a lot of people involved. Okay, number 1, our primary stakeholder, the patients. the doctors, the nurses, the engineers. So there are different people, even regulatory. Okay, there are different agencies or even entities that are involved in our delivery of healthcare. JCI is an example. So we need to make sure that we understand those stakeholders and we need to make sure that we manage them effectively. So why do we need to improve quality in healthcare? Okay, so one might think, okay, so why do we need to improve quality in healthcare? Okay, is there anything that we need to improve in quality in healthcare? But first, let's talk about health and care. So it's a word, health and care. So we care for people so that we improve their health, right? So that's the concept of healthcare. So an organization, your hospital, your facility has as objective, has a vision. By the end of 2030, we want it to be the #1 dental clinic in Saudi. We want it to be, because some of us are in Saudi, we want it to be the #1 mental health facility in the region Middle East, EMEA. We want it to be known as compassionate care, providing compassionate care. So we wanted that, our vision why we put up the business is recognized and appreciated. So business are put up not just for charity. Even hospitals, they have objectives. Some of you are working in private hospitals. I'm sure your hospital are looking at some profits at the end of the journey. So organization, they have a vision and their mission that helps them accomplish the vision. Now, a strategy are placed there so that they could achieve their vision. Like for you, what is your vision, Rashid?
To become a quality team member.
Oh my gosh. Why did you not join our team? You did not apply. All right. Okay. So I'm attending this session roughly to become a quality member, to be part of the quality department. Yeah, because some of them, I don't know, they look at the quality as some people who make the difference. It's like you're already making a difference, but on a larger scale, the quality department have touch. So that's a vision. That's a vision. So what are you doing now? You're now making some strategies. You're now preparing for the examination. You're now preparing yourself so that you are ready to take the goal, to take the role, right? So that's what we're doing. So now we have our strategy. But then, and an organization, they also have their own strategy. They have also the plan how to achieve this strategy. So they have, we call it key performance indicators. How do you know that your restaurant is doing well? Like, for example, coffee shop. How do you know? Well, probably you are achieving about 100 cups of coffee every day and increasing, or probably the sales is increasing, okay, and the expenses are decreasing. I mean, you have to offset that, and you have your profits probably that you can see on the financial side. Okay, now we have performance measures. Like, for example, in hospital settings, how do you know that your hospital is doing well? You might say that, well, our patients are giving us 5 stars in Google review. Or, well, our turnover of staff is very little, meaning we have only 1 or 2 people who are resigning from their job. They are very happy. Well, we have patient satisfaction. Okay, our patient satisfaction is telling us that, well, the patients are happy. Staff satisfaction was also. So these are all indicators or measures. And then we have our expectation versus reality. So we set targets. We set targets. Like, for example, in emergency department, we said that in emergency we wanted that the waiting time of patients would be for priority 3. Priority 3 would be at least 60 minutes. Priority 2 would be at least 15 minutes. Priority 1 immediately. So that's our target. And then reality. Okay, so now we take a look. Is it really happening that priority 3 patients are waiting within 60 minutes? Uh-oh. We're seeing that the patients are waiting for 90 minutes, more than 6 hours. And that's the reality. So now we're now having a reality check between our expectations and reality. And now performance versus output. Okay, so people might be working very hard. That's why when say working hard is something dangerous. People might be working hard, but they're not getting the output that we wanted to achieve. They're all very busy, but they are not really delivering the outcome that we wanted to achieve. So the strategy has to be reviewed all the time, at a periodic basis, at a monthly basis, at a quarterly basis, to make sure that people are performing as expected. In ISO 900, okay, so ISO 9001 is our quality management systems. Okay, ISO 00 says that performance is a degree into, I'm not doing that, is a degree to which set of inherent characteristics fulfill requirements. So we need to make sure that our performance, our activity, our efforts are fulfilling the requirements. Just like for me, for example, you came here to understand about quality. I should be delivering a deliverable set to you. Earlier, we said that at the end of the session, I hope that you will be able to achieve these 5 key objectives. If at the end of the session, we finish until 1 o'clock, and then you did not understand any of this, then I did not deliver the outcome that is expected of me. All right? Now, definition. Healthcare quality, says by IOM, or the Institute of Medicine, is the degree to which health services for individuals and population increase the likelihood of desired health outcomes. So what does it mean? Okay, so people go to hospital. They don't go there to take selfie. They don't go there to enjoy. They don't go there to rest and relax. They go there because they have pain. They are in sorrow, or sometimes they are in fear. They wanted consolation. They wanted treatment. They wanted to get better, right? That's the reason why they wanted to go to the hospital. Now, when they go out of the hospital, did they achieve their objectives? Or you gave them an extra bonus of healthcare associated infection? No, we don't want that. Yeah, we don't want that. So the expected outcomes versus performance, that's what we're talking earlier. Now, when we talk about quality, let me pause the slide for a while. There we go. I stop the slide. Stop share. There we go. Now, when we talk about quality, let's not talk about healthcare. Let's talk first about quality in the sense of our daily living. When people go shopping, they wanted to buy brands that they trust. What's your phone? Oh, you have a very nice iPhone. My goodness. Why do you buy iPhone? Why not Nokia? I'm not saying anything bad words about Nokia. Now, why iPhone?
Quality.
The quality. Okay, what is quality? Quality in where?
Yeah.
Experience, right? The camera. You have a nice watch. Why do you have that watch?
Same.
It gives you a good quality.
Yeah.
Yeah, it doesn't turn you down, right? So when we ask somebody, why are you buying this kind of product? Why don't you buy this brand? My car is Cherry, and probably Dr. Mark, my best friend, and he doesn't want my car. I said, why? It's China. Oh, excuse me, it's quality. It's been with me for the past 6 years. It never let me down. And he wanted like Chevrolet, Nissan, Toyota. Well, they have established themselves as high performance in quality and safety. Nothing wrong about that. Nothing wrong about that. But see how that perception influenced our decision making in terms of buying, in terms of using equipment, because of the word quality. So a quality is something that performs excellent. So in our department, so when there are memo that comes out, we make sure that memorandum are, we have a spelling checker. We make sure that the grammars are correct. We make sure that when I say please see attached, and they are really attached. Not see the attachment, but there's no attachment. We don't want that. We feel embarrassed. Or there are some projects that will go out of our department and say, this project is shabby, it's ugly, it's not worthy, it's not quality. We don't want that. You see, a quality is also a degree, a level of expectation, right? So a quality is a standard, okay? So a standard, meaning to say that there's something that we need to achieve, that we need to reach. Record to the computer, approved, of course, approved. Okay, so you can just watch it whenever you're free, right? So that's what we call quality. And now in healthcare, we wanted also to make sure that we deliver quality care. What does it mean quality care? Now before I share the slide, what do you mean quality care? From your understanding, Nino, good morning, Nino. We haven't heard from you earlier. Let me unmute you. Nino, unmute once more. One more. Probably sometimes people have problem with their microphone. That's fine. Let me ask Mr. Ishaq.
Yes.
Yeah. So when we say we need to improve, we need to have a quality in healthcare, what does it mean? Quality in healthcare.
It should be the expected.
Okay, the expectations,
Yeah.
right?
Met, and it should not harm.
It should not harm. I love that word. Okay, it should not harm. Yes, very good. Excellent. Point on. Miss Nazia. Miss Nazia? Dr. Nazia?
Yes, yes, I'm there.
Hi, good morning.
Good
How are
morning,
you?
good morning. I'm going great. What about you?
Alhamdulillah, alhamdulillah. So, Miss Nazia, when we say we need to have a quality in healthcare, what is your expectation? What are we expecting? What are we talking about?
I think quality in healthcare, we think about the according to me, it is like this. All things will be in quality, like if there is a patient, if the patients are coming to the hospital, and the things which they are getting, like regarding to the starting from the first time till the end, they will get in a perfect quality. That I think.
Yeah, excellent, excellent. Thank you so much. So now that you were talking about it, let me now share the slide because you brought it out, and Mr. Ishaq brought it out as well. So let me now share the slide once more, and there we go. So we're talking about the quality earlier. Okay. All right. So now I'm sharing you the domains of quality. So this is from the Institute of Medicine. So first is safe. We need to make sure that we do least or no harm at all to the patients. Okay, so first, as also said, first, do no harm. And the first thing we need to do is to prevent creating further injuries, further pain to our patients. And unfortunately, there are many instances wherein harm could occur in our healthcare setting. Second is timely. Okay, so sometimes we see delayed disposition, delayed surgery, delayed diagnosis, delayed treatment. So probably the treatment is excellent. Probably the hospital has a very good state-of-the-art facilities. They have a very good medicine. But if it's delayed already, a patient went to the point wherein there's a point of no return. The patient have deteriorated. Yeah, the patient have really gone to where it is irreversible damage. It doesn't help. A patient might be suffer mortality. All right, effective. So the treatment that we are providing, whatever treatment that we are giving or intervention, must be effective. When we say that I have fever, we are treating the cause of fever. Okay, sometimes there are treatments that are not really effective. So like patients go back to the doctor. Doctor, I came 2 weeks ago and I did not really feel well. Oh, okay, let's change your medicine. And then after 2 weeks again, the patient's condition become worse. And the doctor said, oh, okay, probably it's not working. That's not effective. That's not effective. Efficient is maximizing resources. See, in economics, we have very limited resources. Resources could include time, manpower, our medicines, our supplies. And being an efficient means being resourceful to maximize our resources to achieve the best possible output. Okay, so efficient. Okay, so very little resources, but maximum output. Equitable. Now, not probably. Oh yeah, I can see equitability here. When I say equitable, in United States, there is this difference or disparity between treatments between whites and blacks, between colored people and between people who are Native Americans. So there's a lot of studies saying that if you are black, treatment is somewhat a little bit biased toward white and somewhat disadvantaged to you. Here, when you go to Qmatic, yeah, you're going to press or get. Have you taken medicines in our clinic? Yeah, you press the number.
Yeah.
Sorry, there's Qatari and there's non-Qatari. Sorry, but that is an example of equity. Equity means regardless of your religion, regardless of your gender, regardless of your faith, regardless of who you are, it should be given to you fair, in a fair manner. That's what we call equitable. And of course, number 6 is patient-centered. But it means patient-centered, it's not the doctor-centered. It's not the doctor delivering all the what he wants. It must be based on patient-centered. What is our examples of patient-centered care? Like, for example, there are hospitals, okay, wherein they are really speaking to the patients. What kind of food do you want? Okay, so is it suitable? Is the food suitable to you? They provide parking to the patients without charge. But there are some hospitals where they provide charges in the parking area. That's not patient-centered. So patient-centered is a care that is focused on the need of the patient, not on the want of the physician. Now, let me make a difference. When you say, normally, when I was younger, I remember, when I go to the doctor and I tell that I have nose bleeding, the doctor will say, okay, this is what happened, this is what you're going to do, and this is the medicine, and this is what it will be what the output. And then that's it. And he kept on talking, and then now on a person-centered care or patient-centered care, the doctor will tell me, okay, so there are options. One, you could take this medicine, and then you drink it in the morning, and then hopefully your platelet count would be okay. If you don't want to take that medicine, there's another option. There's this nasal spray. If you don't want that, yeah. So what do you want? And as a patient, I'm shocked. Oh, I have a choice. I can choose. Yes, of course. It's you. You are the person being treated. So you have the option. You can choose whatever you want. Now, good morning, Dr. Alam. There you go. So patient-centered. So now patient-centered, they are changing it. They're changing it to, anyone who could guess? Also P, starts with letter P. Person-centered care, okay, or PCC, person-centered care. Why? Because they said that before a patient became a patient, he's a person. We needed to respect him as a person. So a person-centered care also encompasses family, relatives, and friends as a part of the care. So we have our STEEP. What do you mean STEEP? Okay, there you go. So we have our STEEP, STEEP. A safe, timely, effective, efficient, equitable, and patient or person-centered care. Right? So hopefully you'll remember these. We are going to work on these concepts all throughout the day. Now, we mentioned earlier the STEEP, okay, the 6 quality domains. Now, let me go back to these domains and ask you examples. Okay, so give examples, at least 2 examples wherein, we fail to deliver each of these domains. So I'm sorry, you're in front. I'll start with Mr. Isa. So choose any domain and then give at least 1 example wherein, that we are not achieving any of those.
It's timely.
Timely. Okay, so tell us an example or from your experience about timely.
When any patient is admitted with appendicitis, the diagnosis with appendicitis, if the time is delayed, maybe it will go to perforated appendicitis.
Oh my goodness, very true. So Mr. Ishaq has just given us an example of appendicitis. You know, when the diagnosis is delayed, or the treatment is delayed, or the surgery is delayed, it might lead to perforation of the appendicitis. And what could happen? Appendix. And what could happen? There will be more complication. True. Very good. Thank you so much, my dear brother.
Safe.
Safe. Okay. So anything about safe?
The patient is admitted to the hospital and is falling down from the
Oh.
bed.
The patient was admitted to the hospital and he fell. Okay, so that's not safe, right? So and you know the worst thing is the patient fell and he sustained injuries. Now, very bad, very bad. All right. Let's leave Dr. Rachid. Dr. Rachid is in the OR. I don't want him to answer while he is holding scalpel or what. So let's go to Miss Priyanka.
Hi. Yeah, so it would be timely, maybe.
Yes.
Yeah, sometimes, when it comes to insurance, patients need to wait to get the approvals, and yeah, so that's one of the constraints that we are dealing with at present, and we are trying to work on it, Yeah. Although it is not affecting them much, but when it comes to waiting time, they are getting frustrated, and because of that, they are providing us with some negative feedbacks, and ultimately, yeah.
True. Like, in our emergency department, okay, so I haven't mentioned our hospital, right? I did not mention. Yeah, very good. So in our emergency department, some of the patients are waiting for 6 hours. Now they're waiting for 7 hours. And what happens is that they become irate. And one of my friends, have visited the hospital, and he doesn't want to call me. Okay, he doesn't want to call me. He doesn't want me to be a wasta. So he said that I can manage this. So what happened is that he went to the emergency department and he's in pain, and then he fell asleep in the chair, and then when he woke up after 2 hours, he's still there, and his number is still like 50 patients ahead of him, and he's in this emergency department. And said that I'm not going to call John Rich. I'm not going to call him. So he waited for another 4 hours, and then he finally called me and said, I've been here for 6 hours, and no one has been looking at me. So what happened? When I went to the emergency department to see him, he is already shouting with the nurses. He is already fighting with the doctor. And of course, our colleagues, our nursing team, our medical team are writing incident reports, are writing over. They're writing over. The patient was very angry. And I said, I understand why they're angry. Okay?
Yeah, exactly.
So you are in their situation. If you're in their situation, you're in pain. It's an agony, whether that is a toothache or any pain, and people are not looking at you. I don't know who. If you could even greet good morning to anybody. So, timely.
Yeah,
Okay? Thank you so much, Miss Priyanka.
Thank you.
Dr. Nadia, your example. I'm going to unmute you, Dr. Nadia. There you go. There you go,
Hello.
Miss Nadia. Hello, good morning.
Good morning. I want to give example about patient-centered.
Oh, lovely. Go ahead.
Actually, this scenario happened to me when I am pregnant. Okay, I have appointment with doctor. Actually, I am diabetic patient, and my diabetes uncontrolled during pregnancy. Then she tried to tell me about the complication about diabetes and etc. But I can say she said that at rude manner. and I not accepted. I told her, you will not treat me anymore. Then I make complaint for her because she's very rude and she give it to me at aggressive way. Um, and she didn't respect me. I try to explain I am at the pregnancy period that the diabetes change and I become hyperglycemia all the time. She didn't hear me, okay, and she was aggressive and rude. I didn't accept any advice from her.
I understand. I understand. And your experience is something that I'm staying in healthcare quality for that reason. Patient-centered care, person-centered care. My wife and I, we have issues with fertility. So we're working. We're seeing the doctor, and then one of the hospitals that we went visited. When as soon as the OB/GYN saw us, he's a guy. It's a guy. And then he said, "Oh, you're very fat. No, there's no chance." And I
See,
was like,
like this.
I was shocked. I was shocked, and my wife was. Her eyes were. My wife's not really fat. I don't know. From my perspective, she's the love of my life. I see her sexy all the time. But for somebody who in the healthcare to say to the patient that you're fat, there's no chance. And like, there's no hope. He burned. He burned the last hope. We went to see the doctor so that we could see hope in that. Now we know there are ways like IVF or like, but she said that you're fat. I I asked and excused my wife. I said go out for a while, but my wife said no. Who are you to say that don't have any chance without examining me? Without so we feel very bad, just like Miss Nadia have felt. And
No.
whatever she's saying, we don't want to listen to her anymore, to him anymore. And it's really a trauma. It's a trauma. It's a trauma to us. So I'm so sorry, Miss Nadia, that you had experienced that.
Thank you.
Yeah, because we don't want those kind of providers. We want
Yeah.
at the point wherein we are scared, at the point wherein we are afraid, at the point wherein we don't know what to do. We wanted help, we wanted consolation, we wanted a light of hope, and somebody's not listening to us. We don't want that kind of treatment. So that's why I don't know the evolution of medicine have now shifted to from the physician centered to now a person centered because of these experiences. Miss Nazia, go ahead. Your turn.
Yeah, thank you. As I was little bit busy, the kids was making some noise. I'm so sorry for that. So I skipped some part what you are talking about. But regarding the cases which the other discussed, I also want to discuss. But I want to know what this quality means. Means you described something and I missed that part. So what this quality seeking will do with in this kind of cases, like the lady mentioned about Miss Nadia mentioned about her case regarding when she was pregnant and she got she was even hyperglycemic and she didn't got a proper treatment. What kind of things this quality healthcare can do at that time? And as you said about your personal experience, as I am a doc of the same OBG, so I can say like this, how she can do like this, because if we have a patient for
Yeah,
infertility,
yeah,
we will go each and everything about the history of the patient. We will take a thorough history of the patient, the husband history, the wife history, both history, the proper blood investigations and proper investigations which is to be done, and then proper treatment and everything. If even though they are obese, then we can explain them, right? So
yes,
in this patients, as you are, as the one doctor also told about the appendicitis. Okay, the situation, the case of appendicitis, what happens, right? The same can happen with the one who has a arterial blockage, and they can means that patients are there like this, they are having arterial blockage and having angina and going to the doctor, and they need a angiography, immediate angiography. At that time also patient can suffer to be waited for long. And my personal experience, I'm so sorry, might be there are a lot of from HMT. I don't know whether how they are working in this quality healthcare management. Are you there, David? So
Yes.
how the patients here in Qatar, as my personal experience, I am having a cervical radiculopathy medical condition since 4 months, and I didn't got an appointment for that, and it has been so long, going on, slowly. What is this? Why they are not working properly for the quality healthcare management? What this quality healthcare management do in such kind of cases? I want to know about that, please. Go
I got you, and I missed the last question that you were asking. What is?
This actually I suffered a lot here in Bakra hospital, in the government hospitals. That I'm so sorry for saying this. A lot of doctors are present there, but I suffered a lot. Like we cannot get the appointment, even though we are suffering. We cannot get the appointment very soon, and we cannot go for the MRI very soon. And because of this, even though we are medicals, and what about the non-medicals? If they are not getting the proper care, they don't understand anything about the body, what is happening to them. And what about them? Then they are getting the investigations done and the MRI or any scan done very late. Then the prognosis of disease will be very, increase, and they will not get diagnosed, and they are not getting treatment properly. What the quality healthcare management of I'm so sorry for this. What the quality healthcare management of this hospitals are doing. I just want to know about this, and I just wanted to know what is the role call of the quality healthcare management in this type of cases.
Got it. So you might so this is an introductory, and quality have a lot have a role in influencing this person-centered care. First is the perception, the thinking of people. Right now, we are thinking that the doctors knows best. Of course, yes, they studied medicine. We go there for their consultation, and for quality team, they are starting now to help shift the perspective of the whole healthcare system to understand this kind of a paradigm of our practice. Just like before, like in Western medicine, Western and Eastern medicine, like in Chinese medicine, right? So they used to take plants, they put some needles, and now we now have the use of different surgeries, different kind of treatment. So the quality team are number one in role in education, in educating. Number two in transition. Number three monitoring. Number four creating programs that will make the whole healthcare systems comply with these programs, so that the doctors will be shifting their perspective from I am the hero to the patient is the hero. So you see here, quality team have a lot of has a big role in changing, changing what they call the thinking of the whole healthcare system, depending on the organizational vision that we wanted to achieve. So take note. Remember earlier we said that an organization have their vision. They wanted to be recognized as what? As a like in Sidra. Sidra is in Sidra Hospital. They wanted to be a baby friendly, a baby and mother friendly hospital. So what are they doing? The word there is friendly. So they have some programs to make sure that they really provide a friendly and warm environment. So when the mother go there, immediately that connection between the healthcare provider and the patients are instantly created in a click, right? So, and that is made possible through by first, number one, the vision. Number two, on that strategies, the quality team are the one implementing. Okay, so of course, the whole clinical team are responsible in making it happen. The quality team are monitoring. So we'll go further on the different roles of the quality team as we go onward with our sessions. But really, thank you for opening that conversation, Miss Nadia. Ronel, there you go, brother, from our mental health.
Yeah, so since I am from mental health, I would have to choose patient-centered, which is mostly
Oh,
happened in my unit. Yeah,
yes.
because we have the notion that the patient does not have the capacity to choose or to decide for themselves. We always give all the best care that what we think is the best for them without asking what uh what they need, what they want. You know, we're not providing any options because of that kind of notion that they don't have the capacity to choose what is right or wrong for them. But that is very wrong because with their experiences, they know what is more better for their care. So I think also that this, if we missed one thing in this dimension, there is like a domino effect, which is I just realized right now. When we had this patient-centered missed out, you know, the effectiveness of our care also missed out because when the patient disagree of what we introduced to him, he will refuse to the um, other interventions that we provide. So the effectiveness will also miss out. Then after that, the patient will become more aggressive. So the safety will also compromise. And then the discharge or the length of stay will becoming more longer. So that the timely, you know, it's like a domino effect. So which is I just realized right now. So yeah, so that's my I think my perfect example for this quality dimensions. Thank you.
Thank you, Ronel. Are there? So you mentioned earlier about engaging the patients about how they feel. Is there any program that you started in MHS? You know that to engage the patient because right now, we're looking at your patients who are mentally challenged and sometimes uh, it's the difficulty of relating to them, of creating a conversation. So I don't know. So it's your area. So have you started any program or any project, to reach out to the patients, how they feel about the treatment, how are they progressing, or anything about something like that?
Yes, yes, yes. So as of now, we are trying to break the barriers between the staff and the patient. So we started first with the staff. We give them because not all of them has a background of psychiatry. So we give them a basic education. What is mental illness? What are the current issues around mental illness for them to understand? And then after that, we started a new program for the MDT, for the multidisciplinary team. Mostly, mostly we identified that some of the MDT team has no background of psychiatry. So they are the first one to introduce themselves to the patient. And then after, it's like a process of how do you call this? It is like a process of introducing yourself in um, that kind of patient care because some of them are medical backgrounds, community backgrounds, you know. So maybe their notions are very, very different, which is really affects on the way they show themselves, you know. Maybe the level of disagreeing maybe will start a aggression maybe or a conflict between the patient. So those are the programs that we are trying to implement, breaking the barriers.
I would say, wow. Yeah. Like when I was admitted in some facility, not mental facility, but in one hospital here, I didn't even know who are the nurses or who are the doctors, because they came to my ward and said, "I'm going to give you this I'm going to give you that, and then I'm going to measure your temperature. I'm going to take blood. They just leave. They just leave. Right? Like you seem to be not human. You seem to be not person there. You seem to be like an object in the bed. I'm going to take your blood. I'm going to give you this. So now that's the concept of person-centered care shifting. Right. Thank you so much, Ronel. That was a very good eye opener. Now I leave to Ms. Shafija and Dr. Alam later on. We'll go into another topic, and then I'll reach out to Ms. Shafija and Dr. Alam. So we've done that. Now, so there are other potential issues, like example, waiting in ED for 12 hours. Inventory is high, is too high. What is the inventory? There are a lot of supplies, and some supplies are expiring. So, well, to have many supplies is exciting, right? Like for example, groceries. There's a lot of supplies. There's a lot of groceries in your home, but then at the end of the year, it is expired. What do you do with the expired materials? You cannot have them. You cannot consume them. Okay, so CLABSI rate is above national benchmark, of course, even too high. Okay, so the stat is submitted together with the routine lab. So if you take a look at this, poor patient satisfaction, utilization rate is too low, or no show rate, or patient cancellations. So it all boils down into issues. And when we have these issues, again, I will go back to our objective, to our vision. We want it to be a baby or mother-friendly hospital, as per CITRA. We want to be the best general hospital in the region. But then we see these issues. That's not telling us that we are the best. That's not telling to the world that we are really something. Like when you hear the word Johns Hopkins Hospital, wow, Johns Hopkins is one of the teaching hospitals in the whole world, one of the best hospitals in the whole world. When we hear the Massachusetts General Hospitals, which is managed by Harvard Medical School, again, wow, right? Mayo Clinic. When you hear the word Mayo Clinic, you have the sense of wow, what's Mayo Clinic? But if you now look at the issues, okay, they have sentinel events. They have issues where inpatient committed suicide in their own watch, or something like that's not so becoming number one, right? So when we say we wanted to achieve this level of status, and we are seeing these issues, well, that's not helping us achieve our goal. And therefore, we have earlier our expectation versus reality. Now, so what's the intention of performance improvement? Is to close the gap, okay, between the expected state. This is the expected state. So let me make my annotate now. Sorry. I see this is the expected state. This is the target that the hospitals have set. Like for example, the waiting time should be this much time only. The number of infections should be this much only. That's much of data. But then reality says that we are here. We are here. These are our reality. So performance improvement is about closing this. And to close this, that's where now quality improvement comes in. Now, in some of the countries, they are now removing what we say that quality improvement. They call it performance improvement. Okay, so it's all about performance improvement. So it's not just quality, but performance. So out of that, because of that, remember we said that there are different projects or improvement activities that could be created. Now, these are some examples now of potential projects that will be coming out of those issues. Reduction in patient waiting time in ED, improvement in patient flow, inventory reduction or optimization. The turnaround of the staff results will be improved in the sense that we decrease the waiting time, improving patient satisfaction, the 5 stars, 4 stars, reducing infection, hospital-acquired infection, and reducing no-show rates in OPD. Right, so those are just some examples of activities that we could generate. I got a message here. Second. Yes. Okay. So We normally follow the 60-minute, 10-minute break. All right, so we were okay. Thank you for reminding me. Okay, so we're going to have a quick break, 11 o'clock to 11:10. Make sure that you log in by 11:10. Okay, 11:10. Please log in and join us because we will start by 11:10. All right. chocolate sweet. Of course, you're expecting chocolate to be sweet, right? And I was expecting that this is that's sweet. All right, so it's 11:10, and welcome back to our session. Hope that you maximize the 10-minute break. Don't worry, we're going to have a prayer break at 11:40. 11:40, yeah, 11:40. All right, to 12:10. All right, so I have an interesting question here, and then it was asked also by, I think, Dr. Alamor. So the question is our session same with IHI? So IHI, or the Institute of Healthcare Improvement, is one of the non-government, non-profit organizations who are championing patient safety and healthcare improvement. So they have a lot of improvement science, and there's a lot of topics that we are going to touch base with IHI. Now, our session is geared towards different practices, different practices and different disciplines that are included in the examination of the certified professional healthcare quality. Right. So this is geared towards you passing the examination. So there are a lot of theoretical and practical applications that we're going to work out, and I think most of them are 60 to 70% IHI branded. So we're going to include a lot of IHI topics here. All right, cool. All right, so any questions? Any other questions? We're enjoying hot chocolate here in the office. So those of you there who promised that they're going to show up in the office but did not show up. All right, so we'll see you next time. All right, so now we understand the role of healthcare quality and why we need to improve health. Why do we need to have healthcare quality? All right, so we're scared of these low systems coming. Let us close this one. There we go. So well, aside from this, improved patient outcomes, satisfaction, okay, we envision a healthcare that provides truly true care, not just creating errors, adverse events. No, we wanted to go to the hospital to be treated. We wanted to go to the hospital to be comforted. We wanted to go to the hospital to get better, not for us to spend more, not for us to get treatment that are not working, not for us to feel bad, but we wanted to go in hospital wherein we all the things that we feel are going to be improved. So that's an improvement of quality of life. Now, healthcare is a business, so we need to make sure that we meet regulatory and accreditation requirements. Otherwise, licenses, reputation, and at the end of the day, when a hospital have set up themselves in a setting, they wanted to make sure that they maximize also their profit. So imagine, so what's the impact of poor healthcare quality in business? Like for example, like cell phones. If you buy a cell phone and the cell phone is not working or sometimes not good quality, and some of the manufacturers have this refund or return policy, I would return it. Like when you buy anything in Carrefour, and then when you reach home, it's not something that you wanted. It's not something that you need. And so, why did I buy it? I'll go there and return it in Carrefour. If more so, if there are defects, what do we mean defects in quality? Yeah, when you go to the hospital and there are errors, okay, so what do? You go back to the hospital and ask explanation. Why do I have this injury? Why was I have this surgery here? I'm not supposed to get surgery. Why am I having this complication? And to the point wherein, hospitals have to pay compensation, has to, suspend some of the staff for negligence or for malpractice, and that costs money. That's cost money. And one of the legal claims that I processed just weeks ago was not lower than 50,000 reals. One of the claims. So what happened is that I think it's a wrong patient identification issue. So let me use your names. So Rashid, okay, is here in front of me. So I'm typing his name. So but then when I enter when I'm entering his number, his health card number, so I click enter. but then I did not close another patient file. So I closed Rashid's name, and then I work on another patient file. So there's order for CBC, lab tests, and all, and the doctors keep on taking blood samples to another patient. And then here now comes the results. The results are quite normal. I said, we will discharge you. And then the patient left, and the patient did not believe anything that he heard from the hospital. He went to the private clinic, and when he did the blood test in the private clinic, all abnormal results. And it could have harmed him. So he sued the hospital. I want a compensation. If I did not go to the hospital, to this private hospital, I would have suffered. But because I went to the private hospital, I was able to understand my condition, and they provided me treatment immediately. So I have paid cash to this private hospital. You have to pay me. You have to pay me for my psychological damage, for the trauma, and all, and so much. So I don't know if the court will be awarding that amount of money, but there's a lot of claims. Right, so that's importance of healthcare quality. So it's very important. That's the reason why in the organizational chart, quality team are just a few lines below the chief executive officer. Okay, they should not be under nursing. They should not be under the doctors. They should not be under any departments that are operational. Again, they should not be under the executive director of nursing. Why? Nursing is an operational. They should not be under also the Department of Medicine. Why? Medicine is operational. So they should not be influenced at any cost by any department. They should be acting independently. No, that's a question. That's a question in the previous examination. The quality team should be acting independently, free from any pressure within the organization. You cannot say to the doctor, doctor, I think you did a wrong surgery. If you're afraid of the doctor. You cannot tell to your director of nursing that there is a problem in the unit if you're afraid of the DON. So there should be no pressure at all. You should be pressure free. I mean, you don't report to these people. And why? If you report to these people, well, the performance appraisal will be will be in danger. And so we have an example of quality frameworks. You saw this, I think, this slide. Okay, these quality frameworks, if you take a look, on top of it is the leadership. Okay, so the leadership are championing, championing these quality management systems. Okay, so it starts from here. Let me put my. Okay, so it starts here from the performance targets or for the performance goals. And then we have, remember earlier, our expectation versus reality. We wanted to close the gap. And so there are different activities. Now, in these processes, data is an essential part of the performance improvement. From performance target and performance measures and identifying the gap, data is already evidence. How do you say that you have problem with your finances? I told to my friend, I have problem with my money. No, what do you mean? So I'm deficit for this year, for this month. Okay, what do you mean deficit? So my data says that if I do all the budget, the rent, the bills, I'm short by 300 reals, something like that. So that alone is data. Okay, so data to measure, to monitor, and to analyze. Now, you do some improvement. Okay, so you're assessing the problem, that's data. You do some improvement, you're doing also, you're collecting also the data. Okay, so you wanted to improve hand hygiene. Okay, so you wanted to improve hand hygiene. So improve from where? From 30% compliance to 60% compliance. So what do? You now collect data. Okay, data in the sense of how many people are washing their hands, how many people have attended the training, how many people have joined the infection control orientation. So you all collect those data as a part of your changing the process. And At the end of the term or months or years of the project, you're going to collect data. Did it improve? Did the 30% improve into 60%? More or less? So data is essential in any and every part of the process, okay, of the performance improvement. Data will tell you there's a problem. So sometimes there's no problem at all, but people say there's a problem. It's like I have a staff in the previous organization saying that, we have a problem. People are waiting too long in the emergency department. Okay, can you give me the data? How many people are waiting too long? And I said I saw that one patient waited there for 3 hours, but the average waiting time was about 45 minutes. And only one out of thousands of patients. I think that's not a problem. Okay, so I computed, I showed her that the patient waiting time was an outlier. Meaning outlier, that's one case in out of thousands. So I said that we cannot show or present this as a problem to the executive team. Right? So one instance or two instances might not be a problem. Okay, but if you have the data, see, this data tells us that 90% or 70% or even 50% of our staff say that they will resign this year. That's a problem. That's a problem. But if people will just say, oh, I'm going to resign, but there's no data on it, and people, people will say that, oh, there's a lot of people resigning. How many are a lot? That's a question. You need to quantify that. And then you might be realizing, oh, it's just 3%. That's not enough. Right? Improvement and sustaining. What is sustaining? When you have already, like for example, you have achieved 60% of hand hygiene compliance, you need to monitor that. You need to keep monitoring that every month. Because right now, after 6 months, the hand hygiene compliance might be 60%. On the 7th month, it is now 55%. At the 3rd month, it's now 42%. At the 4th month, it's now 22%. It's declining. So you need to keep the data to make sure that you are achieving the goals that you wanted to achieve. Okay. Now, some examples. These are not all, but these are just examples of quality improvement frameworks from the one that we saw earlier. An example is your favorite, PDSA. Right? Remember Schuhart. Remember Deming. Okay, so Schuhart. So the plan, do, study, and act. Now, this basic concept is very simple, right? PDSA, very simple. It's something that we do every day. So you woke up and you went to the shower and your hot water is not running. So now you identified that there's a problem with one of the valves. So what do? You plan. Okay, so now I identified the problem. What I'm going to do, I'm going to replace the valve, the hot water valve. And then as soon as I put the valve, I'm going to check, is it working now? Analyze. And then if not, I'll make the necessary adjustments. I'll do another troubleshooting. Or if yes, then I'll take shower. See, it's something that we do every day. And this PDSA is the foundation of so many quality improvement tools, like for example, IHI. They use this PDSA. But on top of that, there's 3 questions. Okay, what are you trying to achieve? How do you know that a change is an improvement? And what will you do to make this improvement happen? And then these questions. Also, 6 Sigma. Okay, the 6 Sigma. Okay, we have our define, measure, analyze, improve, and control. But they are also focusing on PDSA. Now, what is 6 Sigma? 6 Sigma is an example, a philosophy, or a practice of reducing process variation and improving outcomes. The word here I'd like you to see is variation. Okay, I'm happy that it's working. The word here is variation. What is variation? What do you understand by variation? Like, for example, you have your policies. Your policy says that you need to comply with 5 moments of hygiene before touching the patient, before doing an aseptic procedure, after leaving the room of the patient after doing a aseptic procedure, after touching the environment, or you have accidentally touched an BBF. So that is the procedure. But then you see one nurse or one doctor hopping from one bed to another without washing his hands. That is a variation. Variation is, in other words, deviation. Why do we make sure that we reduce variation? Variation is not standard. Like for example, right now when you do Uber, when you ride on Uber, right now the price is 10 reals. Tomorrow it's 11.5. When it's peak hours, how much you pay? 18 reals. That's variation. It's not comfortable. Unless if you have a standardized, I have already 10 reals here. So next day, 10 reals, 10 reals, 10 reals. Like the metro, it's 2 reals. 2 reals, right? 3 reals. 2 reals. So you can prepare for your money of 2 reals at every day. But if there's a variation, it changes over time. All right. So we don't want variation. All right. So another one is lean. It's about eliminating waste. Do we have waste? We have so many waste. We're not just talking about domestic waste. We're not talking about hazardous waste, but process waste. Okay, we're going to talk about more on lean, on lean methodology in the next following sessions. All right. When we have this philosophy called continuous quality improvement. Continuous quality improvements means everyday process. It's not just when there's an accreditation. Okay, we're going to do this because there's accreditation. No, we're going to continue doing it as part of our life. Just like, for example, when you brush your teeth, after, as soon as you have your meal, you do that. Not only when you're going to go home, not only when you're going out of the house. I heard a mother saying that you only brush your teeth when you go out of the house. That's not true. That's not continuous quality improvement, right? So that's an ongoing effort to improve healthcare processes and outcomes. So as a part of our practice. So examples of quality measures. Remember, we're talking about how do you know that your hospital is doing well. First is the structure measure. Let's say structure. Anything? Can you give me an example of structure? Building,
The
house,
structure of the unit,
huh?
the unit structure.
Oh, the unit structure. Good. Unit structure.
Communication. That's the way of communication.
Okay. The process of communication. Okay, that's one. Okay. So I mean that the systems. You have your telephones. You have your radio, Cisco.
Hierarchy of company.
Hierarchy. Okay. So you have your organizational chart of communication, right? Good. Okay. So the organizational structure. Okay. So structure measures are measures of infrastructure, just like, for example, organizational charts. Okay, so examples are your daily activities. Those are structure measures. Okay, your office, the toilets, those are structural. So anything that you could see, anything that you could follow. All right. So a structure is anything. When we say measure, these are now performance indicators. Okay, clear? So structure is anything that you could see, anything that you could follow, anything that is in place. A process measure is about doing things, showering, administering medication. So it's about walking, exercising, those with a verb. Okay, so structure is a noun. Okay, process is a verb. Okay, so I'm baking, that's a process. I am listening, that's a process, right? I'm attending a training, that's a process, right? So those are examples of process. So measures, again, performance indicators. Now, outcome measures are the result. Again, so I have eggs, I have flour, I have yeast, structure. I am baking, that's a process. And there's a cake, that is the outcome. Okay, I have a car, there's a road, that's a structure. I am driving, that's a process. I reach my destination on time, That's an outcome measure. There are nurses, there are staff, enough number of staff. That's a structure. Tending to the patients, that is a process. On time triage, that's an outcome measure. All right. So let's talk about doctors. There are enough doctors. That's the structure. Okay, process. The doctors see the patient efficiently. Okay, outcome. The patients are seen within the time frame, or the patients are treated effectively or efficiently. Okay, so those are examples of structure, process, and outcome. What about patient experience measures? So these are now measures or performance indicators that deals with patient experience. Okay, what are examples? Waiting time. Are they satisfied with cleanliness? What's their experience, patient experience? Some patients are putting their experience a lot in Google reviews. Said the toilet in this hospital is stinky. The toilet doesn't have bidet. That I did not know that. The toilet in this hospital. So they all mentioned that. It's just about experience of the patient. The parking is too far. Those are experiences. So can we say that the patient experience measures could include structure? There's no enough doctors to see me. That's why I waited for a long time. Take a look. There's no enough doctors. The structure. That's why I waited for several hours. That's an outcome measures. The nurse who gave me this medication pinched me, and I have blue arms because of hematoma. That's process and outcome. So patient experience measures might cover the first three measures. All right, so I think we missed earlier Miss Shafija. Let me see if Miss Shafija is still here. Miss Shafija, before we go for break, give me an example of a structure, process, outcome, or patient experience measures. Any of these measures, please. I'm going to unmute you. There you go. Thank you, Miss Shafija.
Okay, doctor. Actually, I'm not well today, but I'll try.
Sorry. I didn't. You are where?
Actually, I'm not well today. I'm suffering from fever, but I'll try.
We wish you well. Okay, go ahead, rest, and then just stay in. Okay, grasp as many as you could. But if you feel uncomfortable, you could just simply rest. Don't worry. This is recorded. We could forward to you the recordings later on, and you could use this to help you sleep.
Okay.
I hope not. All right. Thank you. Thank you so much, Mr. Fija.
Okay. Thank you.
Yeah. All right. So I'm sorry, Mr. Rashid. Your turn.
Yeah.
Give me one examples before we go for a break at 11:40.
For the
Any.
For the outcome measure,
Okay.
the number of patients seen in ED without waiting more than 15 minutes, for example.
Okay, so that's a waiting time. Waiting time is an outcome measure. Yes, thank you very much. Mr. Ishaq.
You mean I need to go?
Any. You choose structure, process, outcome, or patient experience. And just give one example.
For me, I can go with process measures because I'm doing the NAC study.
Ah.
Our outcome measures was zero accident.
Zero accident is an outcome measure, yes.
Zero accident of trains.
Yes.
Okay. So the process was for us is like a physical measurement. I mean, all patients, we are going for the physical measurement, physical monitoring. If secured properly.
Monitoring, you see the word monitoring, ing. That is a verb, that is a process measure. Thank you very much. All right, so, okay. Let us go with some tools. Okay, there are some tools that we are going to work on. So again, what you see right now are just few tools. There are hundreds of tools. There are so many tools. a prayer now? Now time for prayer?
Ah,
Oh.
still.
So there are different tools. Okay, these are just few of the tools, but we're going to start first with the 5 tools. There are actually 7 quality control tools. First one is the root cause analysis. Before providing a solution, you need to understand why it's happening. And a root cause analysis, or RCA, is the tool that will help us identify the problem. There are many times when there's a problem, people will give solution immediately. Like, for example, oh, I have a stomach ache. Oh, okay, so have some food. Why are you giving food? Because maybe he's hungry. Maybe he's hungry, right? Maybe not. Maybe there's some hyperacidity. Maybe he took coffee. Maybe he's an antacid. Okay. Oh, there's a needle stick injury. Oh, we will send him for training. Why would you send him for training? Because he had a needle stick injury. Why did you think that the training would help? Maybe he doesn't know. So a training might not help. So an RCA is the first step to do when there is an incident. Okay, so not providing solution. So this is the question first. This is the question that came out last November. An incident occurred. What is the first thing you're going to do? So the first thing you're going to do is, number 1, you have to make sure that you are safe, make sure that you are okay, make sure the person is away from the harm. Okay, number two, then sequester the evidence, sequester all the evidence, confiscate all the materials that are malfunction or anything that evidence that will help you in the investigation. Number 3, and then it says there, you now provide solution. And number 4, root cause analysis. So all of these are correct except providing solution. You cannot provide solution without understanding what's the cause. Some doctors are prescribing broad spectrum antibiotic, but without checking for the culture of the patients. And sometimes when the culture comes, it's to their surprise that this microorganism is resistant. So what happened is that the patient has just been taking medication that is not going to help the patient. Benchmarking. Benchmarking is comparing performance with peers, not for the sake of who's better or not. Comparing so that you could learn what are the best practices. How are you doing? How are you doing person-centered care in your hospital? Okay, we would like to learn from you. So that's what we call benchmarking. Of course, when you do benchmarking, you need to compare yourself with the hospital with the same size, same scope. We have FEMIA, failure mode effects analysis. So what is this? So when there are so many processes in the hospital, we wanted to check where could go wrong before an incident could happen. So root cause analysis is when an incident already occurred. It's called investigation. FEMIA, before it happens, we now identify. Very nice. And dashboard is a visual aid that will tell us how are we doing. A checklist is like, okay, did they wash their hands? Check. Is there any hand rub? Check. So a checklist is a way that will help you, that will remind you what is missing and what are the gaps. Okay, before we go to the stakeholder engagements, we're going to have your prayer break. And so hopefully, please be back here by 12:10. By 12:10, we will resume and we will hopefully finish the whole part of healthcare quality concepts. All right. So for those who are praying, for those who are cooking lunch, for those who are then serving lunch or going to pray. All right. So please be back by 12:10. All right. Thank you very much. Hello, everybody. Welcome to our session. I made sure that I cut my hair the same, but some say that I do not look like the same as my picture. But anyway, I'm going to share now the slide. What I wanted to share first before we continue is the scores. There we go. So I hope you're seeing now the screen. So there are 7 of you out of 2, 4, 6, 7, 8, out of 10. So 3 haven't taken the examinations yet or the mock exam. Don't you please do. And if we take a look at the scores, let's go. Let's review the scores. And let me make it bigger. There we go. So if you take a look at the scores, the highest, of course, is 109.5. That's 56%. And we said the minimum expectations that we have is at least 30%. So far, it's still okay. Still okay. Here we have one who is 27. That's not even very far from 30%, but at least 30%. So why we set this expectation is because, none of us were born to be quality. None of us were already quality specialists, right? So it's okay. So that's our benchmark. At the end of our 8-week journey, we hope that you achieve at least 80%. We will not tolerate 70 or 60%. Because for you to pass the examination, you need to have at least 69 to 72%. But I don't want you to get 70%. I wanted to make sure that you are safe by 80%. All right. So I have just clicked posted, and I'm not going to reveal all your scores, but I'm curious, who is this 109.5%, 109.9? Ronel Dakanay from our mental health, getting 109 over 196. Okay. Well done, Mr. Ronel. Well done. The rest, and let's go back again. View post scores. The rest are 84.5, which is 43%. Not bad. 61, 31%. 58 is 30%. 94.5, 48. And 57.5 is 29%. Not bad. Not bad. Right? So at least it only tells us that you have at least some understanding, some knowledge about quality. Okay, and we don't expect you to be very good at the very beginning, otherwise you wouldn't take the course. So this is our benchmark. All right. So we will be working on it. We will have another mock examination next on the 4th session, on our 4th session. So to see improvements on the scores. The questions are just jumbled and changed. So we have a question bank of over 2,000 questions. These questions were recent questions that were asked last November examination, last August examination, last May examination, and February examination from the past 3 years. All right, so people who are taking the examinations are, when they take the examination, we interview them. We ask a few questions from them to make sure that that we have the relevant questions, so we know where are trends of the question. So when it's your turn to take the examination, it's closer to the previous examinations. But we cannot get away with our foundation, with our basics, because the questions could be just changed, but the facts, but the foundations are still there. All right. Now, somebody asked me about about Six Sigma. They said, yes, we do. We do offer Six Sigma. And for example, if you wanted to take the examination for Six Sigma, we have a different organization delivering the Six Sigma. I'm opening it from here. So the examination, it's offered by American Society for Quality. Let me just log in. Oh, they wanted me to change my password. Okay, later. All right, so if you wanted to take Six Sigma, American Society for Quality is the standard in terms of quality. Right, so what are they offering? Okay, so you could first develop your portfolio, but it means to say that if you wanted to go for certifications, there are certifications that they could offer. Let us see. Oh, sorry, you're not looking at the screen. You have. Oh, okay, let's move. Stop share. And let me reshare. There we go. Okay, there you go. Certification catalog. Okay, so the certification catalog here. So they are offering certified construction quality manager, certified manager of. This is what I took. It's pretty nice that it gave me a landed role for VP for quality for the aircraft business supplier. But let's move away from that and let's go ahead with Six Sigma. There we go. So we have yellow belt. Okay, we have yellow belt. This is the lowest rank that they could offer. Yellow belt is the lowest, and then they have the green belt, and the highest is the black belt. So let someone ask about the pricing, full details. So if you wanted to go for green belt, the examination costs about $469. Let me go with that. Same thing? The retake is 269. Yeah, 469. Oh, it's 17. So it's cheaper than CPHQ, right? CPHQ, I think it's $500, $600.
Yeah, almost 2,000 reals.
Almost 2,000 reals. Okay, so Six Sigma green belt. Yeah, so Six Sigma green belt. So they have also a testing window, February 1 to 28. Same thing with the CPHQ. Yeah, but this Six Sigma, the Six Sigma green belt, the level of quality comparing now to CPHQ. CPHQ is healthcare focused. Okay, CPHQ is healthcare focused. Well, Six Sigma is any industry focused. You could work in any industry with respect to quality improvement. All right, so you could work with construction, you could work with engineering, you could work with aviation, pharmaceutical, or management or business industries, wherein they are appreciating quality improvement. Now, someone asked me, please remind me how much is the CPHQ examination? The CPHQ examination, that's NAHQ. Yeah, I think we mentioned that last orientation, but for the sake of the question, let me just answer it. All right, so this is CPHQ examination. Okay, so apply for the examination. Okay, so let's take a look. So where will you take the examinations? You could take the examination anywhere. If you wanted to take the examination quick, 679. Thank you, Dr. Nadia, 679. If you're going to take it in outside the United States, it will be cheaper, whatever, $100 if you wanted to take it in the United States, right? And also, it differs also if whether you're a member or not, right? So again, CPHQ is healthcare focused. If you wanted to be focusing on quality management for healthcare, and the CPHQ is the only qualification for healthcare quality, right? So Six Sigma is industry related, wherever you are, wherever you want to go. All right, let me stop sharing so we could go back to our slide. I hope you had a good break. Now, there you go. We finished earlier on stakeholder, or earlier on the tools. Now let's go with our stakeholder management. Now, stakeholders are very important because they are the people or organization wherein we interact. Without them, business would not be possible. And so, for example, we have our patients. Our patients are our number one stakeholders. Number two stakeholders, internal stakeholders, are your peers or colleagues. Okay, your doctors, your head nurses, your charge nurses, the lab technicians, the security guards, the housekeeping. Those are examples of your stakeholders. The regulators, who are the regulators? We have our Ministry of Public Health. They are the regulators. They are the one who are enforcing compliance to the policies. We have also our corporate. Our payers, insurance are coming in. So we need to make sure that our output coincides with the requirements of insurance. So these are just examples of our stakeholders. We're going to have a separate topic on stakeholder management. So this is just like an overview. Okay, so let me magnify my slide. Sorry, I forgot to put a slideshow. Now, data, we talked about data earlier in our quality management framework. Now, data, I cannot overemphasize the role of data, the importance of data in decision making. And data comes with different sources. And that's why the term that we're using right now is big data. So what do you mean big data? Okay, there are 4 characteristics of a big data. So number 1 is the variety. Okay, variety. So we're going to talk about it, but I'm just going to give you an overview. Variety. Variety means different flavors, different kind of data. Data from the laboratory, data from text, that the text word that is placed in the server, or numerical data. Data like, for example, the triage, how much the temperature, how much the weight, how much are the height, how much is the cholesterol. Those are quantitative data. Qualitative data, okay, so what does the doctor think about it? What's his assessment? So we have different kinds of data, interviews, investigation, right? So variety. We also have volume. We have so many data that are coming in terms of how much data. Imagine in one day in the hospital, there are so many things that are happening. Laboratory are doing tests and they are releasing how many hundreds of results in a single hour. Our clinical imaging are doing the same thing. They're releasing how many clinical imaging results. There are triage in the operating theater, in the emergency department, triage also in the outpatient department. All are coming together. So imagine the number of information. If you have a data, in the previous time, they need one room for the server to put all their servers. Now, not much. We only have a few areas in the hospital wherein they put the server. So imagine it counts for how many paper before, when we don't have the electronic health record, how many paper would that be? When I remember when I'm going to see a doctor, they pulled my file from a bunch of papers. What's your last name? Val. Okay, so they are looking for Val. There are so many V, and then the whole room of papers, whole room of medical records. Now no more. There's big amount of data in a single small storage area. USB is 1 gigabyte now. There's 1 gigabyte USB. Imagine that. My 1 gigabyte before was bigger than than a bar soap. Now imagine the floppy disk. I remember the floppy disk. Very big, 512 megabytes. Now this 1 USB, I have one. It could contain 1 gigabyte. A volume, a variety, volume. We have velocity. Velocity, how fast information can be shared and transferred. Okay, so velocity. Right now, when you type the data, before you need to go to the library to get information. Now, when you type in your phones, in less than a second, Less than a second, information will come in, amount of data. Another one is value, how important the data to a person. That's why we have patient confidentiality. Never share secrets, never share patient information, patient health information, PHI, because otherwise, that could ruin reputation, that could ruin self-respect. That's why they are going to sue you. Right? So we have variety, volume, velocity, value. Okay, so characteristics of a big data. So our sources is not only electronic health records. We have MDER from our rounds, patient surveys, claims data, patient satisfaction surveys, or patient complaints also, or referral from the Ministry of Public Health. Those are all sources of data. And where do we use data? We identify trends. Okay, so are we really having a lot of patients waiting? So we are now looking at, are we increasing in physicians or nurses who have needle stick injuries? Okay, so those are examples of trends. What do we do if there's a trend? We need to squash it. We need to stop it. Because if we don't, maybe people could get killed. We use them to see gaps. Like, for example, we said that the start should be 15 minutes, but the start is 45 minutes when the results are released. So that's a gap. We wanted to measure performance, like, are we doing well? So we provide the data to show that, yes, we are doing well, or no, we're not doing well. And that helps in supporting creating evidence-based decisions or future projects or where to put money. Okay, with the world right now where we in, there's a lot of fake news. See, I saw Putin dancing or having tango with Angela Merkel. That's impossible. They don't, Putin, they're having a dance, but these are all AI generated. So what amount of data will you believe? So data accuracy, completeness, and interoperability means valid data. Okay, so we want to make sure that the data we're using is not a part of the fake news or propaganda. Now, just an overview. This is just an overview, okay, of patient safety and healthcare quality. So things that we look at when we talk about patient safety, harm. Immediately, I think of just like Mr. Ishak had mentioned, fall. We're thinking immediately about hospital-acquired infections. Well, it's a lot of hospital-acquired injury that was acquired in the hospital. It's a shame that people could get who are injured want to go to hospital for treatment and they get further injured in the hospital, which is really, really, really sad. Like examples, wrong side surgery, and like they have to be supposed to be operated in the left hand and the surgery was on the right hand, something like that. That's why I'm thanking for some of our nurses who are really looking at they call it in consent form. A lot of consent forms are saying left and right, and then when it goes now to the surgery to the operating theater, they review. Oh, it's in the wrong laterality. More dangerous, wrong anatomy. Medication errors from prescription, from administration, from dispensing. Okay, so all of those errors, surgical complications, that's why I put there others. Okay, so some strategies, safety protocols. Again, we mentioned about standardization. We don't want variation. Okay, that's why we have our standardization. We have our policies. We have our protocols. More so, we call it clinical practice guidelines. Take note of that, clinical practice guidelines. And culture of safety and regular training and audits. What's the purpose of training? What's the purpose of training? Why do we need training? So, because take note, some people, even though they are doctors, we imagine or we thought that they know already. Actually, no, they don't know also. So we need to deal with everyone as people who are also learning, just like you and me. We talked about equity earlier, wherein no discrimination, no shame, no bias. Okay, so address disparity. Disparity means gap in access and treatment outcomes. We already face a lot of disparities in terms of treatment. So first, they prioritize those queues, and then okay, you can go ahead. So even you're first, and if there's a queue who comes in ahead, it will be prioritized. And they might say, well, this is our country. Again, in terms of equality, equity, we're all the same, having pain. Cultural competence among providers. Sometimes, we have this bias. In the previous studies where we shared in the previous batch, there are some healthcare providers that have bias towards different nationalities, which is very dangerous. Okay? And include policy and practice. Again, we mentioned about that clinical practice guidelines. Now that we identified challenges, it should be easy. The gaps. It should be easy, right? Because we know the problems, so we should solve it. But then the problem are, number one, it's resistant to change. People are resistant to change. I remember when the electronic health records were introduced. Are the doctors wanting to change immediately? No. They wanted to write their prescription. They wanted to write their notes. And I remember one doctor said, I will not use computer. And then finally, we asked him, doctor, if you don't want to use the computer, we don't have any choice, doctor, because we're all going to shift to electronic health record. Would you like to hire a secretary for you? Yes. At your own expense? No. So doctor, we cannot do that. So doctor, you have to learn how to type in the computer. Now he's typing with his two fingers, two index fingers. He typed. That's fine, right? That's fine. Now AI is coming. AI is coming. So if you go to shopping mall, no more cashiers. I went to Lulu the other day. No, not yet. Carrefour the other day, wherein there's only one cashier. And there's a long queue. I said, why is there only one cashier? I complained to the manager. The manager said, if you don't want to go in that queue, we have this self-checkout kiosk. Self-checkout means you take your water, you put the barcode on the scanner, and then you pay with your card and let go. That's very nice, right? So you don't need the cashier to be there. And then in Almira, if you go to Aspire Park, there's a store there that doesn't have any person at all, and there's no barcode. All you need to do is to enroll your card outside and go inside that Almira, get all the food you want, and go out. And then the food is already charged. You don't need people anymore. That's dangerous. Well, but that's easy. For me, it's easy, right? It's easy. It's convenient. It's convenient because you make the errors of human errors of duplicating your order. But I mean, why it's dangerous? Because people will be coming out of a loss of job later on. Yeah, and that's why we needed to adapt to change. Nokia, they have our first mobile phones. Who among you did not have Nokia? We all have Nokia. We don't have iPhone. We don't have Samsung. We have Sony Ericsson. That's all the phones that we have. Motorola, the big phones. They did not adapt to change. Resource constraints. We have limited resources, manpower, less nurses, less doctors. Now, United States and United Kingdom, Europe, and Germany specifically are recruiting a lot of nurses. During COVID, we saw a lot, just right after COVID, 2022, in our hospital, we have 200 nurses who have tendered their resignation. Why? It's not because they're not happy. They're going to UK, Australia, New Zealand, more so United States. So resource constraints. So resource constraints also with our supply chain. Data management issues. Now, so the different data, you have data, but you can't use it. Balancing cost and quality. As a business, of course, cost is important. You don't want to spend. Actually, I mentioned last time, having a quality management is not an income generating. My argument, quality department is an income saving department. If you don't have the quality, you will be paying for poor quality later on. You'll be paying for refunds. You'll be paying for compensation, so on and so forth. And measuring intangible aspects, like how do you measure things that you cannot see? Compliance. So what if people are complying to washing their hands? And we could say that, well, it reduces hospital-acquired infection. No one could see that. No one could see that, right? So the return of investment is not really tangible. But then when a person gets sick of a catheter-associated urinary tract infection or central line-associated bloodstream infection, that's the only time we realize, ouch, this is expensive. Now, there are, of course, different success stories in healthcare quality. Let's say, for example, reduce readmission through coordinated care programs. So we reduce readmission. It means to say that the patient did not come back to the hospital because of same problem. It means that we were able to treat the patient effectively. Now, you might want to say these are self-satisfaction. It improves the morale of the staff satisfaction. At the same time, it reduces costs. For some hospitals, they might be happy because, oh, we wanted to be paid again. But not anymore. Insurance will be making sure that any readmission as a result of poor care will be charged to the hospital. Meaning, if we did a surgery and there's a surgical site infection and the patient went back to the hospital within 7 days because his wound is infected, all the costs will be borne by the hospital. So that's kind of expensive. If we had hospital-acquired pressure injury, that will be borne by the hospital itself. Expensive, right? You might say, well, some of you are working in Hamad. I just heard something earlier. You might say, oh, anyway, it's free. No more. When insurance comes in, everything will be measured in money. If everything will be measured in Qatari riyals. Enhanced patient satisfaction with personalized care. You know, that's about being happy with the service that you read. Trends, we mentioned about this earlier, AI for predictive analytics. Not only predictive analytics, also in precision medicine, also in surgery. Dr. Morset in our urology is using now AI to destroy bone stones. They call it staghorn stones. Integration of social determinants of health in healthcare planning. So now, one part of our domains for examination for CPHQ is the population health. There was one question last time, why do we need to care for population health? It's a part of environmental, social, governance, or called ESG. Imagine, if all people are healthy, then we reduce the cost of spending. And so, social determinants. Expansion of value-based care models. That's why we have our National Value Improvement Collaborative. So take note that we are spending for healthcare. We need to have a collaboration with the whole state of the government agencies to make sure that we get the value. Now we have greater emphasis on mental health quality metrics. Earlier, Ronel was mentioning about speaking to patients, introducing themselves, into asking their feedback about the care that they are receiving. Okay, before we finish session number 1, here's some tips. So we mentioned earlier that quality is a multidisciplinary approach. Okay, it's not governed by one person. And okay, the effectiveness of quality will have to start with leadership. Will have to be proven by data. We'll have to follow the 6 domains. All right, equity, data, and AI, mental health are all trends that are happening very soon. Okay, so we finished session 1. I don't think we need to go for break. We are now going to improvement steps, but before that, okay, let's have 5 minutes, and then we'll have 12:45 to 1 o'clock for the improvements activities. So go ahead, stretch yourselves. I know those who just took their lunch are feeling sleepy. Those of us here who had chocolate are having sugar overload. And those who wanted to go washroom, please do. 12:45, I'll be back. Get some hot water.
Still not noted.
It's not muted, yeah. All right. So hope you were able to get your cup of coffee or stretch a little bit. I know it's just 15 minutes remaining, but 15 minutes could be dragging. I don't want you to be dragging yourself. Yeah. I was just telling them 15 minutes might be short, but 15 minutes is too long, especially if you just had your lunch and So improvement steps, just very quick one, very quick one. We talked about this already. One is, like the PDSA. So same principles, same methodology with PDSA earlier. These identify, assess, improve, sustain are same with the PDSA that we discussed. And at the areas, data, monitor, inform. These are all the same thing that we have shown. We have looked earlier in our quality framework. Okay, so identify, plan, study, plan, do, study, and act. Right? So these are just the basics, and these are the backbone of the quality frameworks. You good?
Yes.
Now, first one is identify the performance gap. So where will you be identifying the performance gap? So take note that you have your targets. So now you measure what's the reality. And then when you measure the reality and it's not with the same target that you wanted to achieve, that's what we call gap. All right. Like for example, when you budget your money, you have, like, for example, 1,000 reals, and then you put all your bills, and then at the end of you sum all your bills, you have like 1,500. There's a gap. That means a gap. That means that, okay, there's a gap that we need to close. Then organize a team. Take note, in any project, you cannot do it alone. It's always multidisciplinary. Okay, why? Because a person's expertise might not be your expertise. So your expertise might not be their expertise. When you all combine together, then you could create a team that is integrated, integral. And then don't forget that you need to understand the root cause of the problem. Do not immediately look for solution. Do not immediately look for quick fix, but look for the root cause. In any disease, make sure that you look for what's causing the problem, what's causing the illness, so that you could provide a tailor-fit treatment for that illnesses. Well, now we're talking about problems for that problem. And then select the change that will result in improvement. So there are many changes, but not all changes are resulting to improvements. What do we mean by that? Well, new job. New job, well, is it new pay? Is it a promotion? That's a good change. That's a change. That's also a change, but that's not improvement. That's also improvement. But what are examples of change that are not improvement? Well, you have a new supervisor. I don't like to have a new supervisor because I don't know if that supervisor is as good as the previous one, or maybe he has this attitude. That's a change, but that's not improvement. All right. So there are changes that are resulting to improvement, or there are changes that are not improvement. So the change for the better. So there are tools that will help you. We talked about PDSA or PDSA, Six Sigma, Lean Philosophy, Total Quality Management. We talked about that. So this is just a review. PDCA or PDSA, almost same. All right. So we talked about this. I think we elaborated that. So I'm just giving you a summary before we go. So the model for improvements. So sorry, the imp has been covered. So this is actually the IHI model. So the IHI has 3 questions after PDSA, before the PDSA. So first question is, what are you trying to accomplish? What is that? What are you trying to accomplish? That is asking for your goal. What is your goal? What is your vision? What do you want it to do? Because if you're just trying to change something without an accomplishment, without an objective, then you are throwing your stones in the air. So what are you trying to accomplish? I'm trying to reduce infection rates by, like that. So that's the aim statement. Next question is, how will you know that the change is an improvement? So not all change is an improvement. We mentioned that earlier. And what changes can you do to result improvement? And then you now have your PDSA. So the aim statement. So this is an assignment that I will be asking you to work on in your facility. So I will ask this due on Tuesday. So you have to think over for a couple of days, Sunday and Saturday, right? Sunday and Monday. So think of a problem in your hospital and think of a change you wanted to make. Okay, so what are you trying to accomplish? No, so don't worry about it. So just think of a problem that is really happening in your hospital or facility and think of a change that you wanted to make. So when we say change that you wanted to make is what do you want it to see? For example, if people are not respectful, you wanted people to be person-centered. So that's what you wanted to see. What are you trying to accomplish? And why is it important? So you wanted to take a screenshot of this right now. So you could make this the assignments later on. Why is it important? And who is the specific target population? And when will this be completed? And how will this be carried out? What? So no. You will just answer the first first three questions, okay? First three questions. Not even the third questions. The first two questions, only the first two questions. So by Tuesday, you have to put in the group chat your answer to the first two questions. So the problem in your hospital or in your facility, and what are you trying to accomplish? What change you would like to do, and why is it important? Because sometimes a problem is not important. It's a problem, right? It's not important. It's not impacting you. Why is it important? Because it's costing you money. It's affecting your well-being. It's affecting your health. It's affecting safety. Those are important reasons. But if there's a problem that is not affecting you, it's not important to you. So I want you to look for a problem in your own setting that is important to you. All right? And then what do you want it to do out of it? So when we talk about change, look at this aim statement. So what are you trying to accomplish? I wanted to improve hand hygiene compliance from 62% to 80% in 6 months. So take note of these words. Improve, this is a verb. What? Direct object, hand hygiene compliance. When we say improve, there should be a baseline. From what? From 62 to 80%. What's the time frame? 6 months. All right. Reduce waiting time in ED by 35% for priority 4 and 5 by August 2022. So reduce, that's a verb. Reduce what? What are you trying to reduce? Waiting time. Where? In ED. Okay, how much? 35%. So there's another way of putting that change. 62 to 80%. That's a change. Another one is I will reduce the waiting time by 30%, by 35%. Okay, so it did not say from, but then it tells you how much change will be created. By when? August 2022.
Okay, in the statement, the sustainability.
Again?
What about the sustainability? It's not need to mention.
No. Right? The question is, how about sustainability? Do we need to not mention? Okay, we will do that later on. Yeah. For the sake of exercise, just for the verb, then what, then the change, and then the time frame. Sustainability, we'll work on that later on. But good point. Improve turnaround time of stat lab results. Okay, hang on. So of CVC from 3 hours to 1.5 in 3 months. Again, improve the turnaround time of stat lab results for CBC from 3 hours to 1.5 in 3 months. Right. So the slides I'm going to share to you right now in our group chat. So yeah, I won't forget that. But don't forget your assignments. No, I'm not going to start with lean philosophy. I'm going to start sharing the slides with you. You will be getting it in 5 minutes. Okay, so by 1:05, it will be sent to you. You will have a copy of the slides. Okay. Now let me answer some questions you have here. Can you upload the presentation? Okay, we can review again. Oh, very kind of you. Yes, no worries. I'm going to share the slides now in our group chat. Okay, so you could review. There are some slides that we are yet to go. Oh no, we already done. Let me finish this. It's just 4 minutes and we're already with 2 slides left. Okay, so your assignments, don't forget, find a problem. What are you trying to accomplish? When I mean what are you trying to accomplish, you have to create an aim statement. And why is that important? So you have to justify that later on. And then lean philosophy, just the last 2 slides. Lean philosophy. Lean philosophy and Six Sigma. Six Sigma is reducing variation. Lean, reducing waste. Oh, by the way, in also ASQ are offering certifications in Lean. Okay, so they are also offering certifications in Lean. Okay, and then JCI standards. Okay, you might want to say, so how can I relate this to JCI? So there are standards that are related to Lean and Six Sigma methodology. Okay, I hope I have answered the questions. I'm ready to answer questions, but we're having tea. If you have questions, please do not be shy. Type it. Type it, and I'll show you the handsome faces of my colleagues here. Are you seeing them? Yes, they are here. Let me answer the questions here. How do we get slides? I think I answered that. Okay, let me see if I could share the slides right now. No, let me see. I wanted to share the slides right now. Let me see. Hang on. So while I'm sharing the slides, you might have some questions you wanted to ask with while we are here. But if ever there are questions that you remember while you are taking shower, while you are doing anything, don't hesitate to just drop me WhatsApp, or you could shout it in the group chat so we could read later on. What is this format? Just a second. And healthcare quality concepts. Okay, now you could, it's downloading in the chat. Okay, there you go. You can see the slide deck. It's a 5.86 megabyte. You can now download it. I'll forward to you. Why did I send it here? I might forget it later on. So I'll be sending it anyway to our group chat and WhatsApp. Okay, so if you cannot download it right now, don't worry, I'll send it in the group chat again. Miss Priyanka, go ahead, please.
Yeah, actually, I would like to ask you something about the portal, LMS portal where you are uploading the documents.
I'm sorry. Can you repeat the question, please?
I would like to ask you a question related to the portal where you're uploading the documents, the presentations and all. The portal, the Team Academy portal.
I will be uploading it there at the same time.
I'm sorry.
Yeah, I'll be uploading it in the portal.
Yeah, actually, I have seen, I saw a lot of pre-recorded videos there. So, will you be taking the same sessions in our later phase, or these are kind of additional documents that you have uploaded with access in our free time? How exactly we can,
How you could download those documents?
No, not downloading. Like, for example, when I opened this portal, I can see that there are sessions like quality management and health data analytics. Okay, analytics. So under this, you have 13 videos, right? So 13 class videos. So will you be taking this live, or these are additional data that we can?
Okay, right. So I would like you. Let's all start fresh. I know that I have done a lot of dancing in the in the Team Academy portal. So I would suggest that do not look at them. I'm going to send fresh one because that it's going to confusing you. It's going to confuse you. There are
Yeah.
some slides as well that from the previous faculty that have been included there. And there's a lot of information and it will overload you. So for now, focus on what we have discussed on healthcare quality concepts. That's all. And then I'll be sending you some documents later on Tuesdays for you to
Yes.
read. You go along. So we are in the same journey. Yeah, for some who are voracious in reading, who have the appetite and have all the time to read, you could all use those slides. But for the sake of step by step,
Yeah.
start with this document with the slide presentation, and then
Yes.
move forward to next, and then move forward to next, so that it will be systematic. So
So
I
I need not have to access them, right? I can only follow the live sessions and the documents that you will be uploading henceforth, right?
yes,
Okay,
that's correct.
thank you. Thank
Thank
you.
you
Thank you so much.
very much. And regarding the term used, improve, suggested to have a baseline. How do we get baseline? How much time needed to make a reliable baseline? All right. So for the sake of your exercise, so I suggest that you have your quality dashboards. You take a look at them. Take a look at your quality dashboards. Or if you don't have dashboard, you look at the problem that you have in your hospital. Okay, for example, and you create because creating a baseline would also require data, isn't it? Right? That's why Ronel was asking. Probably we needed to interview. You don't need to. You don't need to. You don't need to. So probably you ask your quality department, find an issue you wanted to resolve. Like for example, fall. How many? What's our fall rate? You might simply have a simple question like that, right? And then if you get a data, like for example, if we have a fall rate of 0.9%, and you might want it to reduce it. You might want to use that a project, or you might want it to look at your another one of have a great general observation. All right, so you don't from the baseline perspective in the context of the assignment, you don't need to have an accurate data. Okay, you need to have an accurate data. Just make it up, and then we're going to, for the sake of seeing if you are able to follow how to create a good aim statement. So our goal is for you to create a good aim statement. Right, Ronel? I hope that helped. Okay, anything else? All right, so I have extended the mock quiz, the mock CPHQ quiz by Thursday. So our three colleagues who haven't taken it yet, you could still take it. I removed the time. And if you wanted to retake, okay, I'm not going to allow you to retake because that you already know the answer. But what I'm going to do is you have actually a quiz that's coming on Tuesday at the same time. Okay, so the quiz will just be a review how well you have grasped our topic for today. All right. So don't worry about scores. It's just something to follow up. Okay, so I would be able to know that they missed this part, so maybe I haven't explained well on this part. So it's a self-reflection on my part as well. Okay, so I hope you have a great day ahead. So for those who are heading to Russellbrook, make sure that you have your reservations. A beautiful place there. I have been there. I got lost in the desert for 2 hours. That's highly recommended. Enjoy the beautiful first Saturday. It's still cold there. Nice to go out. Nice to go to the parks. Enjoy the fresh air. Have a great week ahead. Goodbye. I was speaking here.